Good afternoon. And my talk is a little bit different. I'll be talking more about systems than individuals. So, integrating sickle cell disease into public health systems in developing countries. Okay, so I'll be talking about the systems, including possible levels of involvement in delivery of healthcare for sickle cell disease, the role of advocates, the current situation in the Caribbean, and looking forward. So I'll acknowledge Dr. Lord for the next two slides. So this is the structure of our Ministry of Health and Wellness, where we have the Honorable Minister, the Permanent Secretary, and agencies that are associated, and then the various subsections. So many of them are critical to managing sickle cell disease in our setting. So the actual healthcare is done by the regional health authorities, of which there are 4, which you'll see that in a while. The legal division is important for sorting out how academic institutions like the Sickle Cell Unit would interface with the ministry. Public relations and communications, critical, getting the message out to the public. Policy Planning and Development Division plans ahead and how to integrate sickle cell into public health. Human resources, actually putting people into the posts that can do the work and training them. Finance is key. When you don't have enough money, things grind to a halt. The ethics division is the ethics committee, falls under standards and regulations. The public health lab oversees our newborn screening lab. And then there are areas like the National Health Fund, which is important for subsidizing prescriptions for our patients, and the Registrar General's Department in terms of national statistics. When we look further at the technical sections, we see that the permanent secretary is here, the financial officer, then the technical officer, who is the chief medical officer, and then you have several different subsets. We actually currently fall under family health services for reasons I'll go into, but other sections such as mental health, substance abuse, epidemiological research and analysis, disease prevention and control, and health promotion and education are important. Why I'm going through all of this is that if we're truly going to be integrated into public health, it's not just a matter of having a newborn screening program. You know, I was so naive. I thought, okay, if we can just get the government to support the test, then we're integrated. But yeah, Dipti's laughing at me. That's all right. But then as time has gone on, I realized that actually, if we're going to truly be integrated, sickle cell disease has to become an issue and a priority in all of these different aspects of the Ministry of Health and Wellness, because otherwise we'll be unbalanced. So as I said, we fall under family health because they deal with women's health, newborns, vaccines, and so on, early childhood. We also are, sickle cell disease is a chronic non-communicable disease in Jamaica and in much of Africa and India. And there are other programs that are important and where sickle cell disease has a major role. So there's a big EU project on reduction of maternal and child mortality. Clearly, sickle cell disease is important there. Adolescent health, we heard from Marsha about these periods of life that are so critical, adolescent health, and also the importance of mental health. But the truth of the matter is that what we have to do to be integrated into public health anywhere is to affect the thinking of the persons who have power. I can't overstate that. And so the Honorable Minister of Health and Wellness sets priorities, guides policy, and that individual person can have a huge impact on the provision of services and has the power to effect change. So when we took that massive leap forward in 2014 to 2015, when we actually achieved the universal newborn screening, what actually happened was the minister at the time thought that sickle cell disease was really important. And so we are meeting with the current minister soon and hope to have similar steps forward. But not to forget that the permanent secretary is the chief financial officer, and he apportions the budget. So this is a person that we have to also try to influence. As for the chief technical officer, the chief medical officer, who directs the staff in terms of training and deployment, and it was the chief medical officer at the time that it set up the sickle cell technical working group. So wherever you are, the system might be different, but if you're in a situation where sickle cell disease is not yet integrated into public health, then the first step is really to understand the system where you are, understand who has the power to effect change, and find ways of actually influencing these important people. So in terms of policy, sickle cell disease was actually included in the National Strategic Plan on Prevention and Control of Chronic Non-Communicable Diseases from 2013. And that made a huge difference. So there is actually a document published by the cabinet which says that, approved by the cabinet, that says that we must strengthen the management of sickle cell disease. And that pushed the ministry technocrats into doing more. So one of the activities was to scale up newborn screening. An indicator was the proportion of pregnant women and newborn screened. And the plan was that by 2015, 100% would have been screened. We've been actually screening pregnant women for a long time, so that was not a change. It was the babies that was a change. And then, equally important, to implement the use of our sickle cell guidelines and have them in primary care clinics and emergency rooms and hospitals, and to have 90% of the healthcare workers trained. Now, whereas we've been holding seminars and the proportion of healthcare workers trained is increasing, we are not anywhere near to this 90%. And so this is still outstanding and still very important. As I had said a couple of nights ago, many of us come from academic backgrounds. And when you're in an academic center, you are the place where there is the most knowledge and experience quite often. So you're in this ivory tower, but we have to move beyond being in the ivory tower and instead be a source of light so that there is a certain level of care right across the jurisdiction for which we have responsibility. And also, still in preparation with Dr. Lord at the leadership of this is, and here we have an acknowledgement that we have a national sickle cell disease newborn screening and maternal program, and that we need to also have a specific strategic plan for that. So it is important that the national or regional or state or province actually has a plan and agrees that it is important. The Ministry of Health and Wellness agreed that the sickle cell unit clinical care guidelines would be the standard of care for the island, and they've purchased 400 copies and have 400 more on order so that it can be distributed across the clinics and the hospitals. But it's not a trivial undertaking. Just newborn screening alone, not the whole program, but newborn screening alone is not a trivial undertaking. Here we have the steps between when the baby is born to when they actually get into good care. And it's very busy, but I'll just run through it quickly. So you take the samples, you test them, then you get it back into the region, and then they trace the babies, get the confirmatory samples back to the lab, back into the region, and then the children are enrolled and get good care. Look at the number of healthcare workers that are involved in this process: midwives, obstetricians, medical technologists, drivers, IT people, the regional focal point, public health nurse, community health aides, pediatricians, medical officers, and so on. The truth is, the only way that integration can really work is if all of these people are well aware of their roles and actually capable and motivated to actually fulfill those roles in the clinic, for the patient. If they just see this as, oh no, not another program added on top of my 150% full-time equivalent that I already do, then we won't get anywhere. So we have to motivate people. And locally, the vehicle that we've been using is the Sickle Cell Technical Working Group, which was recently revamped. And so there's membership from several areas in the Ministry of Health, including Family Health Services, Chronic Non-Communicable Disease, the National Public Health Lab. There are representatives of each of the regions, Southeast, Northeast, West, and South, which is critical because these are actually the people who look after the patients outside with sickle cell disease. And there is a laboratory for newborn screening in Southern region, as well as one in the sickle cell unit care. So the medical technologists are very important in the, and then there's representation from the sickle cell unit and from Ms. Wright, Ms. Marette Wright from the Sickle Cell Support Foundation. You'll be hearing from her later. Which leads me to the role of advocates. You know, when the Jamaica sickle cell cohort study ended recruitment, newborn screening for sickle cell disease in Jamaica ended for over a decade, because at the time the government wasn't ready and willing to take it up. Professor Sargent tried to effect a handover, but it didn't work at the time. It was extremely embarrassing for us when we traveled to conferences, and you know, the data from the cohort was instrumental in other places starting to do universal screening, who had much lower incidence of sickle cell disease than we had. And when they'd say, so how is the newborn screening going? Well, so, I mean, it was a real problem, but it was through the advocacy of what was then the Sickle Cell Support Club, which is now the foundation, that agitated at the government to restart screening. And screening started in this area, close to the sickle cell unit, and then Professor Sargent, when he was doing the Manchester project, moved it to 2 other regions, and then around 2015, the ministry said, yes, we'll go for it. I'm not saying that the fact that the constituency that that minister represented was in the one region that didn't have screening had anything to do with it. That might just have been happenstance. But thankfully, he was very interested in that region joining, and so we cannot underestimate the importance of our advocates. And we need to empower them, we need to encourage them, and we need to let them know how important they are to the process. Because we are competing for a very small pie in the developing world. And I tell people, you cannot have a champagne system on a Pepsi budget. Right? And that is what we sometimes try to do. So much as I'd love to do MRIs on hearts and so on, I'd like to be able to do CBCs and chest x-rays and oximetry and those things first. So there's a very small pie, and advocates help for our politicians to understand the importance of the disease. So the coins of the realm of politics are value for money and votes. Advocates are much better than academics in pointing out that this is value for money because it's saving them from being sick, it's saving children from dying, and also because many people care about it. But there are different types of advocates. So we're all thinking about the patient and parent groups, but we also need professional advocates. We need med techs, nurses, doctors, social workers, surgeons, internists, urologists. We need people who go back to their group and say sickle cell disease is important and advocate that that group is interested in looking after these people. And it doesn't hurt if you can have celebrity patrons or spokespeople as well. So where are we now in the Caribbean? As I said, we started newborn screening in 2015, so 2016 was the first full year. And here you can see one of the issues. We screened more than 100% in some regions, and that just shows us that the collection of data are important. So where you get your denominator from. So we didn't actually go and look at the delivery books. We took data from the statistical people, and we know for sure how many people we screened. So, and then in 2018, it shows another issue. So we had a supply issue. We ran out of Guthrie cards at one point, kits at another point, and so we missed a few thousand children. But that said, for a country of our per capita income and population to be screening over 20,000 babies for sickle cell as newborns in a year when we thought we did poorly, I mean, that is pretty admirable still. So when we look at the region, we have universal screening. Mary Dominic did a very good job with this yesterday, so I'm not going to spend a lot of time on it. So we have some places with universal screening, some places like St. Vincent where we did the pilot and that was the end of it. We have several territories that are very interested in starting, and we want to help and support that process. And then we have some that have absolutely no interest. Once we identify the babies, what happens then? If you're truly integrated into care, public health care, what happens now won't happen anymore. So it's not unusual to turn up at work at 8:30 in the morning and see people sitting outside who've been there for a couple of hours who may have passed 1, 2, or 3 hospitals on their way to the sickle cell unit. And they prefer to get there and sit there even crying with pain because they know they're going to get care once we open than to stop along the way. So if we're going to be truly integrated, there are going to have to be clinics within the public health system that cater to sickle cell disease and training of healthcare workers so that the patients know that they're going to get the same level of care. So in terms of pediatrics, we've actually made quite a few steps forward. So apart from the sickle cell unit, so I should say, I shouldn't assume you all know, the sickle cell unit is open from Monday to Friday, 8:30 to 4:30. We see only sickle cell patients with sickle cell disease, and on an average day, we probably see about 35. Maybe half of them are children, half are adults, half come for appointments, and the other half come because they're ill, and we have a treatment room, which is a sort of A&E type equivalent. But outside of the sickle cell unit, we now have in the southern region some hospitals where there are designated days once a month where sickle cell patients know that's their day. There's going to be education, vaccines easily available, and so on. There are a couple of them in the western region, not so much in northeast, and just one here, but that's for children. For the rest of the region, there are some places where there are specific hematology clinics where, you hear, Swile? Hematology clinics where patients can go to, but most places they're in general pediatric clinics. And then outside of the sickle cell unit, there's nowhere I'm aware of in the region that really has anywhere specialized for adults with sickle cell disease. So we have the same kinds of issues. I mean, at the unit, transition is that when you turn 18, the last doctor who sees you writes your summary and puts it in the chart, you know, what all the things that happened to you as a child. And then the next time you come, you probably see the same doctor because we have family doctors and a few pediatricians. You see the same nurses, the same medical technologists, the same drivers, the same everything. So for continuity of care, that's great for outpatient care. But we have issues, of course, once they need to be admitted. So that's where we are. Where do we want to go? And this is a perfect illustration of the beauty of this type of meeting. This is where we want to. Anybody recognize this slide? All right. So, we are not a BRIC country. Everybody knows what BRIC is. That's Brazil, Russia, India, China, I think. Right, we're not there yet. But yesterday, Dipti shared about the different levels of care in India, from very grassroots in the village, all the way up to centers of excellence where they can do bone marrow transplant. But what was interesting was that at each level, the healthcare workers knew what their role was to do with sickle cell disease specifically, and knew how to move patients up and down this pyramid, and they had access to help from more specialized persons through telemedicine. I think this is a first-rate system, and I think that it is something that more of us in the developing world can ascribe to get towards. What is truly the most important part here is that healthcare workers at every stage are committed to this process of providing care for sickle cell disease. So how will we get there? Well, healthcare workers as individuals, we have to choose to actually spend time learning about sickle cell disease, reading the literature, reading all the, have you any idea how many studies have been quoted over the last 2 days? So it's not going to get into our brains by osmosis, right? We have to actually spend the time and read. But we also have to be willing to be trained, to go to seminars, conferences, to get more knowledge. And in particular, when there are practical things that need to be done, in St. Lucia, our pilot where we were doing heel prick and HPLC instead of cord blood and CAM and agar did not work, primarily because the staff didn't want to do heel prick. They weren't ready to do heel prick. So we need to have staff that are motivated and willing to be trained in both the theoretical and practical aspects of sickle cell disease. So in terms of practical training, we've been trying for some time to have to and from with the ministry where persons can come and spend time at the sickle cell unit and be trained practically in the care, whether doctors or nurses, and then go back into their place of work as a champion. So we'll only get there when we have a team of people that are really, really willing, motivated, interested. And what we need to do is to bottle the passion for caring for people with sickle cell disease and put it into the drinks all across the region and the island. So we are interested in looking after both the individual and the population. And here we have, well, this was the first edition of our clinical care guidelines, in which we highlighted some of our patients from the littlest to one of the oldest. And here we have the second edition, and the patient whose work we've highlighted here, he's an artist. He was actually a statistician, very highly trained statistician, and then he had strokes. And he was unable to work, but his mother helped him to train himself to become an artist. And so we've actually put his artwork on our clinical care guidelines to say that whatever our patients are able to do, we want them to do the most and the best that they can do. So we have to be motivated and passionate about not just helping the individual, but also doing what we can to help the population. Thank you.
Okay, thank you, Professor Knight-Madden. Can we have 2 questions for Professor Knight-Madden at this time? No 2 questions? Okay, we will continue by asking Catherine Hassel from Colorado Sickle Cell Treatment and Research Center, who's going to speak to us on access to insurance for adults with sickle cell disease. Please welcome her.
Thank you very much. So it occurred to me as I was preparing for this presentation to a very diverse and international group that there are two things that the United States are particularly unique on. One is that we have yet to figure out the metric system. One of, 5 countries in the world. And the second is that to discuss insurance as a North American thinks about that is almost silly in this audience, because most countries in various ways have some form of universal coverage or basic health coverage for its populations. And so I've chosen today to broaden my topic beyond insurance and really talk about accessing the healthcare system, which certainly in the United States involves insurance, for the adults living with sickle cell disease. And so it struck me as I thought about this topic, and hearing even yesterday from our colleagues, including the impressive pyramid from India and Brazil, which is set for sickle cell, is there are actually 3 aspects to be considered for each of us in each of our assessments. The first is to have access to a healthcare system assumes the healthcare system exists with the appropriate capacity to give care for those living with sickle cell disease. The second aspect is that that healthcare system exists where you can access it, whether by distance or by, I have my insurance card from North America. And then finally, even if you have the card, and it lives across the street, this healthcare system, will you choose to walk through the door? And this is also an aspect that is often less considered as we talk about especially adult care and access to it. And I would submit that all 3 of those rings on this target to provide optimal health care for adults especially, but anyone living with sickle cell disease, we have to consider all of these contexts. So I'll remind you that it's complicated in the adult world, even more so than for pediatrics. You've seen this slide already, where in mid-adolescence and into early adulthood, the rate of complications increases, the rate of pain increases. There's a lot of challenges, and the burden of disease increases in just as individuals are trying to negotiate the healthcare system, whatever that looks like in your given situation. And multiple organs are involved. It's not simply, although Sweenley, I've got the button, but can a hematologist really render dialysis? I don't know, I don't want to. Can a hematologist really interpret the PFTs? I think this is, especially in adulthood, a multi-system team, as we just heard about, that needs to participate in the care of adults living with sickle cell disease. And that seems easy unless you're in some distant province where there's nary a doctor, never mind one with multiple specialty expertise. So it is a challenge for a healthcare system and then to be accessed by individuals with multiple problems. So we recognize that in poorly resourced areas, there may not be the equipment necessary, literally, echoes, although, where's Vandana? She's got the echo down. MRIs, not so portable, I would submit. The renal biopsy to interrogate the kidney, never mind the dialysis to treat the renal disease. Or even, as we heard Dr. Nightman allude to, I'd prefer to do a CBC and know what the neutrophil count is. Don't you mind about the MRI scan? And even in high resource areas, in my hospital system, you go somewhere else besides my main campus for your PET scan as an outpatient, because the PET scanner is on some other campus. So even in well-resourced areas, the place that you can readily walk to with your insurance card in hand may not be the place where the MRI scanner is or the things that we think we need for sophisticated care. Even if the equipment exists, and I think about transcranial Doppler, do we know how to use it? I do not trust the MRI results for liver iron content at my institution. When Katarina's like, yeah. When I send them to a thalassemia center for my thalassemia patients, we're off by an order of magnitude. And that is because our radiologists in my sophisticated tertiary care center nary have seen a person living with thalassemia in my part of the country. We have the technology, we have the formulas, we have the magnet, but they're not exactly sure how to interpret that information. So it's not always a given just because you have equipment that you know how to use it well. And then in these healthcare systems, did someone know to even utilize the technology even if it's present? Did the provider know enough about the underlying condition to access that infrastructure which is necessary to manage a complicated disease? And then finally, even if that provider has ordered the test, it's interpreted correctly and available, is there the specialist to make that an actionable finding? Is there someone who knows what to do with that information within the healthcare system? So it's not a given and a key element that you have an appropriate healthcare system to have access to, even if it's free. It doesn't matter if it doesn't serve the needs. So it's a key element to have the appropriate infrastructure, the people to utilize that infrastructure, and then persons to be able to take that into an actual treatment plan that improves the healthcare for an individual. So the other thing I'll remind you about then is you have a healthcare system, but it's across the country. It's over the mountain to the north side of the island. Can you reach it? Is it accessible? And I'll remind you, just in North America, as I showed you yesterday, there is a inconsistent availability to expertise, much as the map depicts that you saw yesterday in terms of where sickle cell patients are, and thus where people with at least experience in managing sickle cell care actually practice. The state of California, you can see it's not just about across the country, but within a given state. And then these are, this picture here is of the city of Seattle, and my colleague, Dr. Bender, points out that his clinic is in the middle of this box because that's where all the folks living with sickle cell disease used to live. But in the ensuing 20 years, they've now moved outside the catchment area of his clinic. And while it seems like that's not so hard in places where people trudge literally hours and hours across various nature in countries, this is very hard to do. There's no big mass transit system in Seattle. And so he sees people falling off in terms of being able to be seen, because even in a single city, it may be difficult to get to places where care is expert. Yeah. Uh-oh, here we go. All right. And then finally, if you can get there, I would point out that you may have financial barriers. Now, most of you will say, blessed to not work in the United States. I have my country's health card. So your country's health card, as we've heard from Dr. Knight-Mann recently, has a basic set of services that it will offer, but depending upon the country, its resources may or may not permit the MRI scan that we would hold out as a standard of care, especially in the adult world interpreting complications. And I would point out that, at least to my knowledge in the countries where I have been, there is always another system, the private pay system, the private clinic, if you can afford it. And I'll point out, I traveled, oh crap, we keep doing that, don't we? I traveled to Australia this summer and spent some time in the Northern Territory, and that is that developed country, few minorities, well-established, big tourism, very wealthy country, and the big sign at the airport is, sick of waiting, go private. Everyone there's got a health card, everyone there can get free care, if you're willing to wait for it, or if your disease permits you to wait for it. So there's always another alternative, and there needs to be often, or it develops often, even in countries where there's a country health card that gets you free care. But what does that free care entail? And for very complicated diseases outside of BRIC, right, where there are very good systems, and India, it can be a challenge in many countries. Now, it is true that in North America we have, this is my Blue Cross Blue Shield healthcare card, we have a complicated system. I'll point out that most individuals in North America, in the United States, in fact have Medicare and Medicaid, I keep doing that, Medicare and Medicaid by public insurance. Now, I'll point out that only 3 to 4% of individuals living with sickle cell disease are actually uninsured. The vast majority of sickle cell persons in North America have insurance. But the question becomes what type and what can they access by it. So there have been efforts at healthcare reform in the United States, modest though they may be. We had the Affordable Care Act of 2010. And what this did, I think in a big way, taking a step forward, was it now prohibits that a pre-existing condition precludes you from getting insurance. So now being born with sickle cell disease is not a reason to be denied insurance or to have exorbitant premiums. It did create a place where a private citizen can go and buy insurance, much like big companies do that in bulk with economic power. Although they're pretty pricey, expensive, and many have collapsed under the weight of them. Children who now at to age 26 can have coverage to their parents, which has increased, the graph depicts in the purple, the number of sickle cell disease patients who have private insurance, but that assumes your parents had the private insurance to share with you and to continue, which remains a challenge in especially our sickle cell community. And the result of that, however, is there's been improved utilization of outpatient facilities and less reliant on ED and inpatient facilities. So there have been attempts at least improving, if you will, the United States system. It is true if you can get a job and retain it, you could buy private insurance in the United States. It's cheaper with a large pool, although you still have to pay premiums. And the cheaper the plan, the less provisioned it is. So you can have an insurance card, but if I go walking in with my insurance card and say I need an MRI for liver iron concentration, they'll say, what? And we don't pay for that. So you have insurance, you're insured, but you are underinsured. It's also difficult to maintain employment to keep that if your disease keeps you from adherence to your job because you're needing to seek health care. Medicaid in the United States is a state-by-state program, and it varies from state to state as to what services are provided. There is inconsistency. And if you are a single man or a non-pregnant adult woman, woe to you. You may make way too much money by simply working the corner market to be qualified. And many states have managed care plans, so they tell you where you can go, which may or may not be where the sickle cell doctor is in your particular city or area. There's an opportunity for disability, and clearly sickle cell disease can be disabling. Here are the criteria from the so-called Blue Book for the Social Security disability. You need to have severe pain at least 6 times a year, requiring opiates, but a month between each of those episodes. They are looking to not support persons with chronic pain. You have to be in the hospital 3 times a year as another option for at least 48 hours, again with a month between. Or you can have a hemoglobin of less than 7, at least on 3 occasions. Now here's the deal. So you become disabled. Woohoo, you have health care. You have money. You get your hydroxyurea. Your hemoglobin goes to 10. You stop going to the hospital, and you stop using opiates. And now you're no longer disabled, so they take your money away next year. So it's an endless catch-22 in which people can become trapped. So not only do you have to have the expert system, but you have to be close enough to use it, and your insurance has to pay for you to get what you need in it. Even if you have a card, it may not provide what needs to happen. And these are all things that one should consider as you look in your own situation in your own country. And then finally, I would point out, in conclusion, is that you might have the card, and it might be right across the street where the equivalent of the sickle cell unit is, or the healthcare system in Brazil. But you need time to feed your kids, to work so you can be on the job so your employer doesn't fire you. You can either choose to pay for the gas to get to the clinic, or to get to work, or to get to the grocery store, or to get your kids their school clothes. So there are lots of competing priorities that young adults need to potentially consider. There may be transportation. There's a great van system here. I love it. You can get to Mona from anywhere on the island. In North America, that'll cost you a couple $100 maybe, or at least the taxi says they'll come, but they don't show up. Simple things as transportation, even across a city, can be complicated. And then there are cultural and psychosocial barriers. There is the fear or the reality of discrimination. You anticipate that when you go into the emergency room, they're just going to call you a drug seeker yet again. Why would I go and face that unless I'm really very desperate? And there's a stigma in many different ways in many different cultures potentially associated with sickle cell disease. So people may have the card and they may even have the ride, but they may choose not to engage. And you've seen some of this before, but I'm just going to reiterate it to make the point. So there's a decrease in adherence to things like transfusion in adolescence and young adulthood. This is a study that you saw yesterday that I cast a slightly different twist, or at least emphasize that there was a 36% mortality when people transferred from a well-known pediatric program to a beloved provider, Dr. Samir Balas in Philadelphia, who welcomes everyone with open arms, with no barriers, with accommodations for when you need to come, with no financial issues, and 36% of them died because they simply opted out. And this is, I didn't know this, but I looked it up on the internet. This is the Mario Invincibility Star. Right? They are invincible. They don't need those blood transfusions. They were just being made to do it all that time. Or they chose competing priorities, and they paid the ultimate price for that. There was a healthcare system. They had the insurance card. It was an individual choice, one that we need to better inform. And so it's not just about the insurance card or the national health card that gets you free care. The question is there a system that can actually has the capacity to address this very complicated disease state? Are you close enough to a place that can provide that comprehensive care, and can you access it? Does the card actually get you what you need within that system? And then, even when those things are true, does the individual, especially the young adult, choose to engage it? Because at the end of the day, our goal is striving to give optimal care every time to every individual. And all three of those things, and a host of others we couldn't talk about today, are necessary for access to health care, well beyond the insurance or the national health card. With that, I'll stop and take any questions. You have a minute for questions. Where is that? Who was counting minutes earlier? All right.
Any questions?
I have a question because there are so many questions. See, I still have to learn so much. So I'm glad you shed light to one part of the equation of access to care that the patient himself. We always talk about poor access to care as it's always on the other side. But you probably know, everybody that has worked in sickle cells, especially in adults, knows that our no-show rates is exceedingly high. I spend hours and countless energy in trying to reach patients to have them come to clinic. And the no-show rates, when I drop the ball a little bit, goes to 50%. If I have 10 people calling the patient, it's 30%, but there's an enormous use of our resources. And I just want to know what you think about this.
So here's what I would say, because some of that is, I have a 24...
I'm a wonderful provider.
Yeah, I would come see you. So I have a 24-year-old and a 22-year-old young man, and they are horrified when they have to do any kind of extra paperwork to like renew their license to drive. They're like, what? I have to go through paperwork? So I would say that just at a time where our young adults are facing freedom from what they see as being compelled to do healthcare, to have to go to all those visits when they're feeling great because we've done such a great job in pediatrics, right? And then in order to go, they have to fill in the 14-page Medicaid application. What? I have to do the paperwork? And if they don't do it right, they have to go back again. And sometimes you have to camp out. And those who work through healthcare systems that are complicated, you got to keep even your national identity card up, right? And they're like, I don't think so. I'm not going to do that. So it's not even that they're trying to blow us off, but then when they call and they say, you don't have your card, you don't have Medicaid, it's not covered yet, here's a thing to sign that you'll pay all the bills. They're like, I don't think so. So it's not even just that some of it's invincibility. Some of it is they're finally free of that healthcare they never really wanted to do because they haven't grown up their brains yet to realize. And some of it is then we place before them in some cases this huge burden that daunts even more mature, shall we say, adults or people who are really eager to jump through any hoop necessary to assure their health care continues. It's a very vulnerable age as an example, but it's no less burdensome for the 30-year-old or 40-year-old adult who yet again has had their Medicaid, speaking now for the United States, their Medicaid program switched because they missed the letter that came in the mail, and now they're assigned to the crosstown hospital where they don't do sickle cell care because they didn't specify they wanted to stay in the system they've been in for 10 years. So it's complicated, right? And it's not all just on them like they are insufficient human beings. It's a complicated scenario.
Thank you very much. We now close off this section on the public health aspect of sickle cell disease management as we welcome Rosalind Stewart from Johns Hopkins Outpatient Center. She's going to tell us about education of healthcare professionals through ECHO. Please welcome her.
Thank you very much. So we're going to talk a little bit about educating people with sickle cell disease. I do have some disclosures. First disclosure, I'm not a hematologist. I'm an educator, program builder. And the work that I'm going to talk about today is sponsored by HRSA and the Gail Campbell Woolley Foundation. My other disclosure is later I'm going to have a commercial. So we're going to talk about ECHO, and I'll describe what that is in a minute. We're going to talk about echo for sickle cell disease, and then we're going to share the metrics that we've developed in the Northeast region of the United States. Now, this is part of the treatment dissemination projects that Kathy mentioned yesterday. So this is just one of the 5 regions in the United States, so just our work. So what is ECHO? ECHO was a concept that's really genius and fairly simple. It was started in New Mexico, addressing how do you care for hepatitis C in an area of the country where the doctors per capita were very small, not very many doctors, a lot of people with hepatitis C, and the average wait time for a visit was about 9 to 12 months. And this was around the time when curative treatments for hepatitis C were coming online. So this very smart guy, Dr. Aurora, thought about his medical training and how when we go to clinics, you have precepting and you develop this kind of feedback loop to teach young doctors or other people, how do you take care of this illness? So we took this concept and decided to have these distance video conferences where you could have multiple people participating. So there's one expert or a few numbers of experts talking to many people at once to share and disseminate knowledge in this very hub and spoke kind of model that helps replicate and disseminate information across distances. Oops, backwards. So really, it involves very simple technology. So most people, if you have a smartphone, if you have a computer, you can participate. You can just do it by telephone. You don't have to do it by video. But video conferences gives you that kind of warm, intimate feeling where like you're in the same room as people. And it involves the similar concepts that we had in our training with precepting. Is it is very case-based, very interactive. And so this engagement from the learners with the experts develops this sense of community. And it actually has been shown to help the providers that are out in the community, far away from the ivory towers, if you will, feel less isolated and feel more part of the community in which they are in. It is not telemedicine. Telemedicine has a role, certainly, but there are distinct differences. And I illustrate these differences more here. Like I said, in ECHO, it's a hub and spoke model, where in telemedicine, it's really one provider and a patient over a distance. Telemedicine is billable. ECHO telementoring is not billable. It is an educational conference. There are no identifying patient characteristics. We don't talk about people in terms of their name, but just about the individuals, so that you can do it across state lines and don't have to worry about, in our country, medical liability that goes with that. Lots of benefits of having an ECHO model. It is promoting best practices, promoting the NHLBI guidelines. It promotes lower costs of care because people can receive care in the area in which they are. If they're going to where their health card indicates they should go and they live far away or don't have access to the subspecialty centers of excellence, which are kind of far in between in the U.S. So ECHO was built for hepatitis C, which at the time was a fairly common illness in the United States. And we've learned that ECHO, we already know, that sickle cell is a rare disease, orphan disease in the United States. And so its model of care delivery is very different than, say, taking care of somebody with hypertension or diabetes, which is a very common illness in the US. So Synergy, that's the Northeast Region Treatment Demonstration Project name, has 16 total sites within our area, including 2 Caribbean sites. We have Puerto Rico and the U.S. Virgin Islands and the District of Columbia. So when the idea was that the TDPs were going to start echo for sickle cell, we had to look at, well, how are the echoes put forth for most illnesses? And we meet many of the criteria. The management certainly is very complex. You know, it involves multiple specialists frequently, or at least experts that understand the pathophysiology of sickle cell disease to be able to help other providers learn about the illness. Lots of involving treatments, you know, different medicines, different approaches. The guidelines came out and we needed to disseminate those, etc. It has huge, high social and medical impact. We said that sickle cell is a rare or orphan disease in the United States, but in almost every hospital, it's in the top 3 or 5 readmission diagnoses in almost every hospital. There are lots of serious outcomes. Kathy just pointed out that adolescents who fail to transition appropriately frequently die from their illness because they are not engaged into appropriate care. So we meet all of the criteria, but it's not a common illness. But our goal for launching the ECHO was to improve provider knowledge. We had done a survey just before we launched ECHO to figure out, well, what is the provider knowledge, just baseline in primary care providers in our area? And we learned a couple of very interesting things. One, the average age of a primary care provider in our area was about 10 years after their training. So, and then the second thing we learned was that they knew all that they knew about sickle cell disease came from their residency training. So the information they had was 10 years old. And we went through lots of evidence this week, these past 2 days, that was more cutting edge and much newer than 10 years. So we know that the care, the knowledge that they had was insufficient. And the care that they delivered, therefore, was not high quality. So we want to improve provider knowledge, and we want to improve the skills in which they practice. And at least in the United States, there's a whole bunch of bias towards individuals with sickle cell, that they're frequently treated very poorly because some of the providers have a priori biases towards the individuals that are fairly disrespectful and frankly not true. And our goal is to overall improve the quality of care delivered to patients with sickle cell by an increased number of providers. So we launched our clinic in 2015 using this hub and spoke model. And just as we have pointed out, it took a small cadre of expert individuals to host. This is our hub, to host every session. We have our sessions once a week and have a variable number of attendees. So it's not just for primary care providers. And in fact, when we started it only for primary care providers, we learned that they were a little less interested because of lots of other pressures. They don't have time necessarily in their very busy day. They're not afforded breaks while they're seeing patients. And they maybe only have 1 or 2 patients with sickle cell disease. It was primarily hematologists that were coming, but hematologists that were out in the community and frequently also were not seeing a lot of patients with sickle cell disease and still needed expert training. But also we have advanced practice providers, NPs and PAs, ED providers, hospitalists, so people across the care continuum for sickle cell disease were coming to get the training that they needed. And then all other aspects of that team that we need, case managers, social workers, community health workers, geneticists, everybody. So here's how our conferences go. We have 2 cases. We start with one case, and this is a case presented by somebody in our community. And we talk about it. We are more adult-focused than pediatric-focused, but we do talk about pediatric cases when we have them. And they generally fall into two main categories. Either they're medically complex, or they have a lot of psychosocial complexity. So it is terrific that we have a psychiatrist who's an expert in pain management on our hub expert panel. We take a break and have a brief didactic covering some aspect of sickle cell disease, frequently affiliated with what the NHLBI guidelines say, or something that we learned that was cool from ASH, or something else that we just want to share, but short, much like these didactics here, only about 15 minutes. And then we have a second case. Everybody, and I have the topics here. Everybody that comes can earn CME, so all the participants get CME. And we have recently rolled out MOC credit as well. So that is free to the participants. So here is our impact since we started. We've had over 1,600 participants. And it's divided by a base of about 240 attendees, which means people come over and over and over. So their knowledge is growing over time. We have 144 providers, which means 100 of our attendees are not MDs or PAs. They're other members of our team. And we cover 73 different spokes. That is across 25 states and 3 countries. And so we are growing. We've given about 318 hours of CME credit away, and so far about 17 MOC credits. Here's our distribution. We are more in the Northeast region because that's where we targeted, but every time we go out and speak about ECHO, hopefully we pick up a few more spokes and be able to gather interest in people coming to get education about sickle cell disease. And each session, each year, we are growing. So when we first started in 2005, we had about 5 people showing up each session, meaning we look at our TV screen and we have 5 little boxes of the participants. Now we have about 14 little boxes, so 14 different sites at any one time. And not everybody comes every session, of course, because we have 73 spokes. So you might be able to come only once a month or every other week, and it's all good because every time you come, you could learn something. And then we do surveys. Now, there's no hook for the survey, so our response rate is fairly low, but it is pretty significant. And remember, primarily, we have hematologists. So people who studied hematology are in our audience. And we significantly improved how they feel that they're capable of managing pain, how they can manage a crisis, how to titrate hydroxyurea, how to initiate hydroxyurea, how to recognize the indications for starting hydroxyurea, and how to recognize acute chest syndrome. So things that we feel are pretty basic to the healthcare of people with sickle cell disease. And 67% of all our 244 participants said that they will change their practice as a result of attending our clinic. So we think that's pretty successful. And as a result, in the Northeast region, we have launched other echoes because we are Wednesday at 1 Eastern Standard Time, but maybe that's not a convenient time if you live on the Pacific Coast or if you're someplace else. So these are all our other sickle cell echoes. We are starting one with the help of the with the help of our government, to have another attempt to engage primary care providers. That's the STAMP. It should actually launch in January. Across our region, for all told, so the other echoes are more nascent, we've had over 2,000 participants over time with 387 individual attendees. We've given away a total of about 330 CME credits. So I think developing a significant impact just even in our region. So we have increasing utilization and increasing provider confidence in delivering care, which is part of our goal. We haven't measured knowledge yet, but that's the next thing that we're rolling out. We're going to look at our MOC credits to make sure that people's knowledge is growing as appropriately through kind of pre-post surveys. I'm going to end with our commercial. Here is our echo. This is how you could sign up to attend. You can share it with anybody. It is free and readily available. Wait, I got one more slide because I got all the other echoes. I'm just letting people take pictures. Second commercial. Here are all the other echoes in our area, but it's the same contact. So if you got the picture of the first slide, if you email us or call us, we will help connect you to the echo that is most convenient for you. Thank you. Yes, do you have a question? Oh, no one's told me it's not, so 30 seconds.
So, as a hematologist, I've been trained to be a clinician, but nobody's taught me how to be a teacher or a speaker or an advocate or an administrator or many of the other things I need to do. Looking at something like Project Echo, I would imagine there's probably their variety in how much of how to be a good teacher various presenters have. So can you give some suggestions on resources for us as clinicians to learn to be good teachers to make sure that we're really maximizing what we can give forward in projects like this?
Certainly, I can. So you are absolutely right. In medical education, it's largely focused on medical education and not about disseminating that work. There are sections of conferences, particularly in the area of general medicine, where they have teaching skills and curriculum development skills, and I would encourage people to seek out those conferences and those workshops to develop that expertise. And I suspect that in most universities, there's a CME available to learn how to develop curriculum and develop a lecture and teach that lecture well. Thank you.
Thank you so much.